Good morning, everyone. I am Dr. Amber Luong. I'm over at the McGovern Medical School. I'm sorry I'm running a little late this morning. For some reason, I got my times all mixed up. But in any case, I'm glad that I'm able to join you guys. So what I wanted to do is so just give you a little bit of background. I'm an ear, nose, and throat doctor, obviously, but I'm a rhinologist. So most of my time I focus on sinus cases, endoscopic skull base. And I also have a basic science lab, so I'm interested in understanding the pathophysiology. So you'll see that kind of come through a little bit as I go into some of the understanding of this disease called allergic fungal rhinosinusitis. So with that, I'll go ahead and get started. So what we're going to do this morning is spend a little bit of time talking about the clinical presentation of allergic fungal rhinosinusitis and the means of making the diagnosis. We're also going to look into a little bit, I don't have a lot of time this morning, but want to discuss and highlight some of the pathophysiology of allergic fungal, mainly as it relates to potential treatment for the disease, as well as then talk about some of the unique surgical as well as primarily surgical, but medical management of allergic fungal. So we'll start out with this clinical presentation. I was hoping that we would be able to do this more in real time. But I'll kind of go through the thought process for you guys, and then maybe at the very end I can take some questions when you're thinking through this presentation. But this is what we oftentimes see. A 26-year-old man in Texas presents with years of worsening right-sided nasal congestion. And now he notes that there's a mass that he can see kind of popping out in his nasal cavity. And you can see that picture there. This is, even with an endoscope, you obviously can see the mass poking out. But it's been going on for years, and it really hadn't bothered him until, again, when he saw this mass coming out. He has a long history of allergy symptoms, you know, your typical sneezing, rhinorrhea, nose blowing, but it does mention really thick mucus when he blows out his nose. And then of course, when you start looking and thinking about this, you want to ask him his medical history of other things, and he denies any asthma. He does admit that he's been seen by an allergist when he was younger with either like blood or shots, meaning skin test, and was noted to have a lot of allergies, and he's a non-smoker. So with this, you want to start thinking about a differential diagnosis. And so, you know, you want to ask about what additional things, when you think about a history, and what are you thinking about in terms of diagnosis. So, you know, you're going to want to ask what's going on the other side. So you can see that on the right side, there is a polyp filling up the mass. So you're not going to be able to get much more of a view inside of his right nasal cavity, but you'll want to take a look at the left side. You know, can you visualize polyps on this side? Can you visualize any other mass? You want to get a history of bleeding. You know, so in your differential, you want to think about potential masses, but obviously on initial evaluation, it does look like a polyp. It's got that water balloon kind of appearance, and it doesn't look angry. However, other things that can still be hidden behind polyps are inverted papillomas. So you still want to keep that concern of a mass of some sort in your mind, especially if it turns out that there's a unilateral presentation. Other things is, you know, when you have polyps just on one side, you may still want to think about etiology. So is it a dental etiology? Is this cystic fibrosis in a young gentleman showing up with such severe polyps? So you want to think that and keep that in mind. So what about the workup? So when you're thinking about the differential diagnosis, make sure it's a very extensive, with obviously the higher ones or the more likely diagnosis higher up on the list. And then in your workup and or in your history, you're trying to go down that to work through that. So you're going to ask about, is there any bleeding, any vision changes, any neurologic changes, decreased sensation, those kind of things. And then in terms of your workup, what we typically do is obtain some labs, especially if you're concerned about CRS with nasal polyps or chronic rhinosinusitis with nasal polyps, and then of course a CT scan. So here is this gentleman's CT scan shown here, as well as some of the labs. So what I normally get is a CBC with DIF, as well as a allergy panel with specific interest in getting fungal specific allergy allergens as well as a total IgE. And so you can see here that his eosinophils are normal, and his total IgE is a 742, and this is extremely high. So keep in mind that typically, and it will depend on the reference lab, what is considered normal, but for us, anything above 150 is considered high. And most of my allergy patients, or even chronic rhinosinusitis with nasal polyps, if they have elevated total IgE levels, it's usually within the 300 range or something. So anything in the 700 or thousands makes you want to think about allergic fungal rhinosinusitis. And you see here, he's got multiple elevated fungal specific IgE levels. And on his CT scan, you'll see this is a classic CT scan of an allergic fungal. You get this hyper intensity in the middle of the sinus cavity. You get expansion of a sinus cavity, and oftentimes you may get dehiscence of the bone, especially the thin ones between the eyes and between the brain. Then this is really interesting, and we'll go a little bit into that. But when you compare it to CRS with nasal polyps, even the eosinophilic version, what happens is like your AERD, aspirin exacerbated respiratory disease, what they'll see on a CT scan is often thickening of the bone rather than expansion, which makes me think that this has been going on a little bit longer, and because the sinus cavities are actually able to remodel and then eventually erode through the bone. So what about other imaging? So the things that you want to think about is whether or not there's true erosion of the bone, and you're concerned about potential intracranial cavity contents going into your sinus cavity when you're going to operate. Although you'll see a lot of erosion, and in Texas we see a lot of this allergic fungal, I've stopped getting MRIs, but it is something that is often asked, which is what happens when you get an MRI. So this is another patient, again, similar CT scan as the previous patient, but you get this expansion of the frontal sinus. So you're looking at an axial CT scan, and you get this hyperintensity on the right frontal sinus and less so on the left frontal sinus. So what does this look like on an MRI? And this is a classic question that often shows up on some exams, which is the MRI. So you see here that the concurrent MRI for this patient, again, the right side, interestingly, this is a T2 weighted axial. As you can see that the CSF is lining up. T2 is more we'll highlight more water-based, and we'll go a little bit into that. But you can see that the inflammation on the left side is noted, so thickening, this is complete opacification, but this thickening of the mucosa is noted by this hyperintense signal on the left side. But interesting, on the right side, where you see a lot of this hyperintensity on the CT scan, you get this drop signal. And so it looks like there's nothing there. And this is a classic presentation of allergic fungal rhinosinusitis in terms of the MRI versus the CT. And to show you why this happens, and it's because when you go in and operate on these patients, you'll see a hyperintensity or a very thickened mucus, and it has a lot of iron and metals from the fungal debris, as well as a high protein level. And so you can see why this happens in a T2 if the complete opacification from the sinuses on that right frontal was low in protein and a lot of watery based mucus, then it would show up as a high level or a bright signal. And that's what we see with the mucosa on that left frontal sinus because of the inflammation and blood going into that signal. So you got that high signal. But what happens is that thick eosinophilic mucin in allergic fungal has a lot of metal elements and high protein, and that's why you get this drop signal noted on the MRI. So keep that in mind. So in order to make the diagnosis of allergic fungal rhinosinusitis, there have been a number of different diagnostic criteria, but I think the most classic one is the Bent and Kuhn criteria. And there what you have to have is the presence of nasal polyps, which is what we see here, type 1 hypersensitivity to fungal antigens. So we noted that on a fungal specific elevated IgE levels. Characteristic CT scans, we talked about that, which is the expansion or bony erosion. You get the signal hyperintensity within the sinus cavity, consistent with this spherous magnet element of the fungal debris. And then the other ones are needed, or the diagnostic criteria is met through going to the operating room. So you'll see eosinophilic mucus without fungal invasion into the tissue, right? So once you start getting fungal invasion, now you're looking at an invasive fungal sinusitis, whether chronic or acute. So you should see no fungus invasion into the tissue, and ideally seeing positive stain. Now this can be sometimes difficult for the pathologist to pick up for you, and so sometimes this criteria is loosened, but if it's a classic allergic fungal, this is not difficult to obtain. So some of the issues with the clinical diagnosis, as I mentioned, is sometimes when the patient is a redo or a previously operated patient, the polyps may not necessarily be so evident. And also, if you put a patient on prednisone, especially high doses of prednisone, you may not see those polyps afterwards. So sometimes that criteria is a little bit difficult to obtain. And also the other thing is what we're seeing is that there is this spectrum of eosinophilic mucin in chronic rhinosinusitis. And so this was a study done in 2009 where they looked at this distribution. And so here's allergic or eosinophilic fungal rhinosinusitis, where patients have known fungal sensitivity. And then you can see that allergic fungal sits right in the middle of that. But sometimes you can have aspirin-exacerbated respiratory disease patients also. Obviously, they have eosinophilic mucin, but if they have fungal sensitivity, you can see that that can override. So a lot of this diagnosis sometimes can be a little bit difficult, and there's this argument about exactly how do you make that diagnosis. I bring that up just to tell you that sometimes that diagnostic criteria is not so straightforward. Now, the interesting thing is, especially if you're in the South, and some of you may have seen that in the classic allergic fungal rhinosinusitis, it's very different from how CRS with nasal polyps presents. And this has just been interesting to me, and especially to other people, when you think about the treatment of it. Allergic fungal rhinosinusitis can be very different from its bigger cohort of chronic rhinosinusitis with nasal polyps. And this has been some presentations that have been brought out through studying these two different populations. So obviously for both of these cohorts, you see polyps in both the CRS with nasal polyps and allergic fungal. The presentation is often very different. So allergic fungal patients often present younger than 30 and not too uncommon, maybe even in the teens, high teens or early 20s, while CRS with nasal polyps often present a little bit older. The total serum IgE levels, as I mentioned, is dependent on the atopic status for CRS with nasal polyps, but often very high in allergic fungal. Interestingly, the peripheral eosinophil levels are very typically normal in allergic fungal, but elevated in CRS with nasal polyps. And we've done some look at asthma presentation or the concurrent of asthma, but many of you have heard that asthma is often a common comorbidity with CRS with nasal polyps. This is unlike allergic fungal, where the presentation is generally in the 20%. The prevalence is often only in the 20%, while it's often high in 50 to 60% in CRS with nasal polyps. So just some interesting things that makes me and others think that allergic fungal is a unique clinical phenotype as well as an endotype of CRS with nasal polyps. So just to give you a little bit of historical background, this was originally described in 1988 or 83 as an allergic aspergillus sinusitis, and was initially linked to allergic bronchopulmonary aspergillosis, which is found in the lung. The epidemiology, as I sort of alluded to, is very unique for allergic fungal. So those of you who are in higher altitudes further up north, where it's often more cold and not as warm and humid as down here in Texas and in the South, you'll get less presentation of allergic fungal, or you may get a presentation that's not the classic allergic fungal that we see here in the South. Again, that presents in the younger adults or adolescents. And interestingly, we see it oftentimes in the lower socioeconomic status. That may be due to environmental exposures in this population. It may be that they show up to their physicians a little bit later, and so the presentation is a little bit different. And keep in mind that unlike other fungal sinusitis, the patients are immunocompetent, meaning that in invasive fungal sinusitis, those are immunosuppressed patients. This is an immunocompetent with an atopic history. Why do we think that fungus is actually linked to the pathophysiology of allergic fungal rather than just a side issue, which is because you get this sinus expansion that's typically filled with a mucin that is really filled with fungal, not the spores, which you and I breathe in all the time, but the fungus actually germinates into a hyphae, meaning it has a chance to have this hyphae, and the hyphae has a lot of protease and activity and other antigens that can then stimulate a type 2 immune response. There's also evidence of an elevated fungal specific IgE, meaning the adaptive immune system has seen the fungus and has made a type 2 immune response to it, which is the characteristic immune response that is of allergic fungal as well as CRS with nasal polyps. So this to us suggests that the fungus is actually playing a role in the pathophysiology, at least with this subtype. And so some of the work that we did, and I only have time to highlight a few of them, is that we looked at healthy control, CRS without nasal polyps, CRS with nasal polyps, and allergic fungal, and specifically took out mucin from the sinus cavity at the time of surgery. And then we treated it with the mucin to kind of free up the fungus and see in those secretions, when do you see fungal growth? And as you can see, this allergic fungal has a nearly 100%, while CRS with nasal polyps is not too far behind it, almost about 50 to 60%. Fungal reactivity, what we did was design a ELISpot assay, which is a little bit more sensitive to look at the type 2 immune response to see if they have fungal memory, meaning did their T cells remember or have seen the fungus that are in the sinus cavity. And we see that yes, for allergic fungal and CRS, the fungus that is found in the sinus cavity actually was able to be seen and exposed to the immune response and resulted in a memory, a T cell memory in it. And so you can see there. So to us, this is pretty strong data that suggests that it is involved in the driving this type 2 immune response. We also have looked at the epithelial cell barrier. People have looked at the epithelial cell barrier, which keeps the environment away from the inner mucosal layer. And when you look at that, a group from Sarah Weiss and Emery looked at this, and they found that in allergic fungal rhinosinusitis, a lot of those proteins that are important in the barrier are defective in allergic fungal sinusitis, and it decreases the ability to keep the environmental antigens out in the environment and allows kind of a more leaky epithelial barrier, as you can see there. But we've also looked, and it turns out that, and you'll see this more in your careers, that this epithelial cells not only serves as a functional barrier from the environment to the inner mucosal layer, but it's actually an active part of the immune response. So, various different things out in the environment can trigger and activate the epithelial cells to release these epithelial cell-derived cytokines, IL-25, IL-33, and TSLP, which are orchestrators of this type 2 immune response, which is, again, characteristic of allergic fungal as well as other CRS with nasal polyps. And so we looked at epithelial cells taken from patients with nasal polyps as well as allergic fungal. And what we see is that when you stimulate the epithelial cells with the fungus, it does cause an increase, excuse me, I didn't label this properly, of increase in IL-33 expression, which again is one of those epithelial cell derived cytokines. And you can see that this expression is more prevalent in CRS with nasal polyps than those with CRS without nasal polyps. So again, I don't have time to go into all of this detail, but basically fungus can stimulate the epithelial cells as well as leak through the epithelial cells to activate this type 2 immune response. And we now know that CRS with nasal polyps causes this type 2 immune response that's characterized by this IL-4, IL-13, and IL-5 with like eosinophils and mast cells and elevated IgE, all these things that are characteristic of the immune response that we see in CRS with nasal polyps and allergic fungal. So this is a figure that we published in one of our papers that kind of highlights some of the pathways that have been highlighted that fungus can do to ultimately drive this type 2 immune response. And so fungus can create proteases. They can go through the epithelial barrier. They can stimulate various different receptors leading to these epithelial cell-derived cytokines, which then can drive this innate immune response through innate lymphoid cells, as well as the type 2 immune response through T cells. And you can see how staph, and I don't have time to go into all of this, but there's a lot of literature about how Staph aureus can play a picture. So staph can also help stimulate through the superantigens this initial drive started by fungus to lead to this really hyperimmune type 2 response. And other cytokines, which are going to be important when you think about the ultimate medical treatment, right? So many of you have heard about some of these biologics that are being investigated. And in fact, a year ago, or almost a year ago now, the dupilumab or Dupixent was just approved for CRS with nasal polyps, and it blocks this IL-4, IL-13 arm, which then ultimately leads to the activation of mast cells and driving other immunoglobulins, as well as mucus productions and so forth. So it's really going to be important for you all to think about and really start knowing some of this pathophysiology, as some of the medical treatments that are coming out now are geared towards some of these pathways. And it'll be really exciting to learn and figure out if these drugs that were studied primarily in CRS with nasal polyps and specifically excluded allergic fungal, whether or not they can be effective in allergic fungal rhinosinusitis. So keep that in mind and realize that it's going to be important for you all to really know some of these cytokines that are being talked about that are driving this type 2 immune response. So with that, I'm going to shift gears now and think about the treatment, thinking back at our patient that we presented, a 26-year-old male. And so usually the first treatment, although you can initiate medical treatment, but the first treatment for allergic fungal often requires surgery. And so when we're thinking about that and we are thinking about surgery, it's really important to think about what are your goals for surgery, right? We're not going to be curing patients, unfortunately, of this inflammatory disease, but there are some important goals that we're trying to obtain in order to minimize recurrence or minimize the driving of the type 2 immune response that results in these polyps and buildup of eosinophilic mucin, which then drives these symptoms that the patients are suffering from. So number one, we're trying to clear the eosinophilic mucin, which also harbors the fungal triggers that are, as you can, that I would argue is driving that type 2 immune response. It's also important in terms of confirming your diagnosis. You're trying to clear the nasal polyps as well to improve the patient's symptoms of pressure and nasal congestion, as well as providing access to the disease mucosa for your topical medications, whether that's steroids or just saline irrigations to be able to clear their mucin down the road. So I'm going to start first about preoperative management. When you've seen this patient, you confirm that they do need to go to the operating room. What about systemic steroids? Well, this is a very important step for patients with allergic fungal to minimize inflammation and hence minimize bleeding. I will tell you, though, that a lot of the academic centers will not give preoperative steroids just because we're trying to understand the pathophysiology and therefore collecting tissue, and we don't want to alter the immune response in the tissue. And so oftentimes, many of you who are in training and see your faculty, they may not give preoperative steroids, and that's primarily because they're interested in collecting the tissue. But oftentimes, preoperative steroids can be extremely helpful to minimize intraoperative bleeding so that you can be able to obtain your objectives in a more efficient and clear way. It can also dissolve the mucin in the polyps, which can complicate your diagnosis. If I use preoperative steroids, what I normally do is you start it about 3 days before surgery with 30 milligrams of prednisone, obviously in giving your patients the typical warning about potential side effects and issues, and understanding the patient's comorbidities such as diabetes, and understanding that that can increase sugar. So you want to keep those things in mind. But if you're thinking about giving it, 30 milligrams of prednisone or something similar 3 days or so beforehand can be very effective for intraoperative bleeding and decreased inflammation. Some unique surgical considerations in this patient population is the fact that, and I showed it here with that patient, is a unilateral disease. And this is a really interesting perspective. And we think about this, that some of these surgical considerations I'm going to highlight are some of the things you should keep in mind, and we'll go into a little bit more detail. But oftentimes you do not want to manipulate the non-disease site, so because the possibility of seeding a high level of fungal hyphae into the undiseased site. Now, what you'll find, though, when you start treating these patients for a longer period of time or see more of them, many of the unilateral presentations may ultimately present bilaterally as they get older because of the continued exposure, but you don't want to be the one that seeds that other side. Recurrence is also can be highly dependent on the complete clearance of eosinophilic mucin, again, that harbors that fungal hyphae. Bony erosion does not necessarily result into mucosal barrier defects. So a lot of these scans, and I'll share some of them with you, can be very impressive with complete expansion into the intracranial cavity, with bony erosion between the sinuses and the intracranial cavity, the brain side. But what you'll find is that the mucosal barriers are intact. So going in and doing surgery, you need to be aware that that is a weak spot, but does not necessarily mean that you're going to expose a CSF leak. Surgery can be more difficult because you're trying to clear this mucin. Oftentimes it can cause an increase of 2 to 3 hours just trying to make sure that you've got all this really sticky mucin out of the sinus cavities. But at the same time, the mucin can be your friend in that it expands a lot of the areas that are more difficult to obtain, such as the frontal recess, as part of the disease process, making it actually a little bit easier and to surgically manage. So this is just a classic presentation of the eosinophilic mucin. For those of you who don't get to encounter it, this is a left maxillary sinus. It's been opened up, and a suction is placed into the maxillary sinus, and we're trying to pull that mucus out of the sinus cavity. You can see the sticky nature of it. Some people talk about this, the peanut buttery consistency. You can see those kind of a brown tannish blobs on top of this mucus. This is a classic allergic fungal mucin that you'll encounter in these patients. And if you, what we do in order to confirm the diagnosis, if it's still in the open, is you send that mucin to your pathologist for permanence, look and asking them specifically to look for fungal hyphae, eosinophils, and Charcot-Leyden crystals. So these are, again, classic criteria for allergic fungal, and maybe sometimes explored on some of the standardized tests and steps and so forth. So some of the unique surgical goals for allergic fungal is, again, to clear the eosinophilic mucin. And one of the sinuses that can be extremely frustrating and difficult to manage is this maxillary sinus. Many gray hairs have been grown on my head just trying to get all this mucin out of the sinus cavity, the maxillary sinus cavity. So some of the tricks that I've picked up over the years, and maybe you picked up others through your attendings, using a microdebrider to really clear all the polyps. You may be using a rad, an angled one, so a rad 60, 90, and even higher to get to some of those deep angles. And what you're trying to do is not necessarily try to clear all the polyps, but you're trying to identify pockets where mucin can be trapped in there, and that's why it's important. Another trick that I've picked up is using a pledget to wick out or gauze or whatever you want to use, but to stuff that into the open maxillary sinus after most of the mucin is gone, to sort of wick out some of the hard to reach places of the mucin. Frontal instruments sometimes can be very helpful to get to hard to reach places to clear some of the fungus, whether it's to just kind of dislodge it or to actually grab the mucin, although I will tell you that's a very frustrating experience trying to grab mucin and pull that out. But the frontal instruments can be very helpful and sort of help dislodge it. And then irrigations. Warm saline irrigations to help dissolve some of the sticky nature of the mucin can be helpful on a syringe. And make sure you really evaluate that fungal, the maxillary sinus in all those angled, difficult to see places with a 45 and a 70-degree scope, because oftentimes I'll think that I've cleared the mucin, and then you go in with a 70-degree scope and find pockets of the mucin. And again, this is a big reason why you'll lose, you'll get recurrence, is because of the fact that eosinophilic mucin was left behind. A nice little tool at the end, once your sinus cavities have all been opened, is this Hydrodebrider. It is a device that's from Medtronic. I don't have any conflict of interest with them. I don't have any issues or with any conflict of interest with them, but you can see here that this Hydrodebrider, you can use you connect it to an IV bag, and you can irrigate all the sinus cavities at various different angles, because it's a malleable end that you can angle at various different angles. You can get, this is going up into the frontal sinus, so you can really irrigate out all of these sinus cavities once they're widely opened, to try to get out and clear out even mucin that you can't appreciate grossly. Another surgical goal is really complete dissection, and this can be very difficult, although the mucin, you can see here on the sagittal CT scan an expanded frontal recess, but you can see how the frontal sinus can, or the ethmoid, this is actually an ethmoid cell that's been expanded into the frontal sinus. You really got to make sure that you get all of this out. So even though your frontal sinus is open, or the access of it to this frontal recess is open, you really got to make sure you take down this bony partition so that all of these cells are opened up. And sometimes very difficult, especially as the frontal sinus expands really high up, and some of your instruments will have a difficult time reaching it, but it's going to be really important that you make sure you open up all of these small sinus cavities, and similarly removing all the ethmoid partitions, because you may have mucin. So for example, if you don't recognize this cell, you'll have mucin trapped here, and you're definitely going to have a recurrence sooner than later in this patient if that cell is not opened up. Another thing, this is one of those scans that I told you can be very impressive. This is a CT scan, a coronal CT scan, going from anterior to posterior. You can see extensive expansion of the frontal sinus cavity there. Let me just play that one more time again. You can see this really expanded frontal recess going up into high up in this area. You can, right there, that was the posterior aspect of it. The ethmoid sinuses are expanding into the intracranial area, although not into the intracranial intracranial cavity per se. A unique characteristic I mentioned is this unilateral presentation. So you can see here that it looks, that at initial visualization, it looks like maybe both frontal sinuses are involved, and it would be in your planning, you may consider doing bilateral sinus surgery, but if you really carefully look at your CT scan, this is the axial, you can actually appreciate that the left sinuses are clear, and it's really the expansion of this frontal sinus laterally that's causing the closure or what seemingly closure of that left frontal sinus. So just be aware, and you really don't want to instrument the non-disease sinus side if at all possible. And so you might have to do some tricks to get to the contralateral side without going into that side. Again, some of the pledgets can be helpful, the irrigations can be helpful to get over there even when your instruments cannot. So with that, I will tell you that allergic fungal rhinosinusitis is just a really fascinating disease. And some of the things to kind of keep in mind when you're thinking about this is that it can present unilaterally, but you want to make sure that you're not dealing with an actual tumor or mass. So we still send all the pathology to, or all the tissue to pathology, just to make sure that there's nothing there in terms of a tumor, and meaning an IP, because an IP can sometimes be hidden in a patient with allergic fungal rhinosinusitis, especially in maybe the older patients where the polyps may have been present for a long period of time. We do see sometimes this transformation of polyps into an inverted papilloma. So you want to keep that in the back of your mind. But this is the one type of CRS where you have a unilateral presentation. And with that, as I mentioned, there are some surgical considerations when you're managing allergic fungal with a unilateral presentation. And it's not uncommon for you to also get bilateral presentation. So I don't know if you guys paid attention, but that first patient, I didn't mention that he had already had surgery when he was younger. So his other side had already been opened up from a previous sinus surgery. But you can see here, this patient had not had previous surgery, as the ethmoid partitions are in place. But it can often happen that this patient with unilateral disease will down the road or many years later present with bilateral disease. But sometimes they often can be cleared if you catch it early enough and do a good job on their first time around and clear that mucin and do a good job surgically, that they don't present with bilateral disease. You'll have accumulation of a unique fungal mucin that really needs to be cleared with the surgery in order to minimize recurrence. So I didn't get a chance to talk about the recurrence, but this is the disease that can often recur frequently and frustratingly very early on if you don't get all those cells opened, if you don't clear the mucin. And even when you do, they can sometimes recur. And that's why, going back into the disease pathophysiology, the post-operative care is going to be almost as important as the surgical care. So a lot of times after the surgery, after you've really taken the time to clear all the eosinophilic mucin, I will start these patients on saline irrigations, finish out or initiate a systemic steroid post-operative regimen. So if you started them on pre-operative steroids, I'll do a complete 9 days of 30 milligrams of prednisone, or initiate a 30 milligram for 9 days at the time of after surgery. Start them immediately on saline irrigations and see them back within a week, so then I can catch any early irrigation, any early recurrence, remove any debris that has maybe picked up. And this is actually the patient population that I would consider some of the steroid-eluting stents that you may have seen or heard about. I like them because they release steroids locally, but also have an open configuration that will then not block off some of these sinus cavities that you've already opened up, where mucin can be trapped in the sinus cavity. So I'll use that. And so with that first initial visit, I'll kind of clear the sinus cavity of any debris or any crusting without taking out the steroid-eluting stent at that time, and then start them on a topical steroid. And then at 2 weeks, I'll remove that steroid-eluting stent and then really start them on a topical irrigation of steroids. And at that point, they're off of their oral steroids. And then I kind of see them very soon afterwards, meaning 3 weeks afterwards, just to make sure that if I'm dealing with recurrence, I can start escalating my topical therapies earlier, and maybe even having to restart them on oral steroids to minimize this recurrence and try to clear their sinuses out of other things. But this is the patient population, if you've tried and you've escalated all your topicals, may be considered for some of the biologics down the road, because they can recur. But what I've found is that if you can do a really good job in that first sinus surgery, especially in patients who present unilaterally, that might be all that that patient needs. And then they're on just a topical steroid, even a saline irrigations, and maybe just a steroid spray, because remember, they do have allergic rhinitis. This is a unique CRS subtype, the other ones, and again, mentioned that sometimes it's difficult to manage. So just going back,
To all the attendees, we will see if we can get Dr. Luong back on. I think her internet may have frozen up, so hang on just a minute. There we go. We got you back.
Sorry about that. Yep, my internet just went out just in
It
time.
happens. So we heard you were just on your last summary slide. I think on the last bullet point is what we had heard.
Okay, so but basically, you know, it's just a really unique disease process. Starting from the presentation to the workup, meaning that you want to see if allergic rhinitis so that you can manage other comorbidities. And then surgically, there's some unique surgical considerations for this disease that you may not necessarily have to worry about in other CRS with nasal polyps.
I love your tip about using the plugets too. I'm going to have to try that one. That is, I had not heard that before, but I like that. So.
Oh man, I've been dealing with this for so long that,
Yeah.
you know, and maybe Brett, if you've done this before, but you can spend hours
Yeah.
Taking this out. And it's just the most frustrating experience because you think you've cleared it and then you go in with your 45 or your 70-degree scope and you're like, oh my gosh, there's still more. And you're just shocked at how much mucus that this patient can carry. And it's always a fun time in the operating room because you get a lot of oohs and ahs. Yeah. Even the anesthesiologists, as they're kind of creeping out, like, what are you digging out? And how much of this can you, like, and then all of a sudden the whole OR is like rooting for you. But yeah, it can be frustrating because, you know, maxillary sinuses should be quick and easy and, you know, 30, 45 minutes. And here you're like on hour number 2, still digging out mucin. So yeah, so plugets have worked great, you know, using various different instruments to sort of get to those areas. You may even have to do like a more widened enterostomy, you know, even considering a mega enterostomy if you're going in for the second time. You know, those are some things that I've all had to do in my patients.
To reiterate your too about the kind of latitudinal things in the country, well, I guess throughout the world, but I was up in northern Indiana for a couple of years in practice and did fellowship down in Georgia. And I've noticed up in Indiana, I had a total of 2 patients in 2 years that had AFS, one of whom was in Arkansas during the winters. Here in Kentucky, it's a kind of a mix between the two. And down in Georgia, it was like 85–90% of our patients seem to have AFS. So it's a, and this is anecdotal, but it seems like the mucin is even more sticky the further south you go.
Oh yeah, yeah. So, so clearly there's an environmental contribution, right? Which to me even further highlights the fact that the fungus is playing an active role in the pathophysiology, as well as probably some other genetic stuff. So, so I think that down the road, you know, as we're starting to get into this really fun era of, you know, novel medical therapies, you know, maybe highlighting, I think the allergic fungal is one of the ones that are going to be very reasonably managed with maybe some topical, if we can try to target some of these epithelial cell kind of receptors or epithelial cell, whatever that the fungus is like activating, then we could really get there, and that would be awesome. So I think that'll be a really fun future going forward.
That's So for any of our viewers out there, does anybody have a question for Dr. Luong, either on the chat or the Q&A? We'll wait a few seconds here, Doctor, and see if we have any questions that pop up. But really appreciate that. That's a great topic to cover, and it's obviously a difficult one, particularly technically in the OR, like you're talking about, getting all the fungus out of there. I have trouble with the lateral sphenoid personally, but
Oh yeah, well yeah, so that's another one, because you're kind of worried about some of the areas where it's eroded through, right? You know that there's no bone around the carotid, and then oftentimes the optic nerve, there's a little bit of stuff behind there. I agree, and or you're trying to avoid going to the other side. So very frustrating, fascinating disease. And I think that, I first encountered it during residency, because I did my residency at UT Southwestern, where they started talking about it early on, and it was like a bug. And ever since then, I've just been fascinated about the disease, the surgical management, the medical management, trying to understand how fungus plays a role in the whole thing. And also, it was just fascinating, because I came in like in 1999 when the Mayo, and I was a resident when it all came out. Yeah. And they were saying fungus was driving everything. And so that was kind of neat to live through that. And it, just like everything else, it's like a spectrum, right? First, it's like, well, fungus plays a role in everything. Now fungus doesn't play a role in anything. And now I think it's going to be right there in the middle where it should be, right? So probably fungus probably contributes to the pathophysiology of probably other CRS with nasal polyps as well, but as well as allergic fungal, but it's not everything, and it's not everybody, right? Clearly not CRS without nasal polyps. So I think it's just a really interesting disease, and a great model to sort of even learn more about CRS with nasal polyps, where there's just so much heterogeneity that it's hard to study. And so picking a disease like that, or AERD, and trying to find some of those pathways, and then ultimately translating that to some sort of medical or even surgical therapy.
Yeah, and for the viewers out there, I just want to reiterate how important Dr. Luong is with her basic science within the world of rhinology, and really the world of otolaryngology in general. She's also actively involved with the Women in Otolaryngology at national levels, a lot of committees, and so she's been a leader in our specialty, and we really appreciate your time today, Amber, for being with us today. So
no problem, Brett. Thank you for inviting me. And sorry I was running a little late.
That's okay.
A little brain fog as we work from home and are totally confused all the time, since my kids are always here. So I'm like, what day or what time is it? So I apologize with that. And I guess, more and more of us are going back to work. I know in Texas we've opened up. So our residents are actually back at work in both the clinic and the OR. So it's been great. I'm very impressed that you guys have been able to pull off something that I think we've been talking about for a long time, in terms of trying to provide, some sort of online residency education. And now we've got 3 covering all the time zones. So that's very impressive. And thank you for doing that.
Yeah, thank you for being with us, and I'm going to transition now to Dr. Shakin from Pittsburgh. He's going to talk about salivary endoscopy. So thanks again, Dr. Luong, and we'll see you later, okay?
All right, take care. Bye-bye.
Dr. Shakin, if you can